So it's my pleasure to introduce David Dunkley, who is a researcher here at the Jewish General Hospital and the Lady Davis Institute. He's an assistant professor of psychiatry and an associate member of the psychology department at McGill University. He was trained in clinical psychology at McGill University and got his PhD in 2001. He then pursued postdoctoral training in longitudinal diagnostic assessment of psychiatric disorders at Yale University. And that was followed by a postdoc here in psychotherapy studies and depression in our department at the Jewish General Hospital. Dr. Dunkley has received FRSQ Chercheur Boursier Awards. The primary goal of his research has been to examine the mechanisms through which perfectionism is a personality vulnerability factor to depression. He has received numerous fellowships, obtained grants from federal and provincial agencies, and has published several articles in respected journals using structural equation modeling and path analysis and multi-level modeling as a primary data analytic techniques. In 2005, he received the Canadian Psychological Association President's New Researcher Award. So it's my pleasure to introduce David. Thanks.
Thank you very much, Phyllis. So by coincidence, my parents arrived last night, and I didn't tell them about this research day, but over breakfast this morning, my mom asked, is this something where anybody can go to? And I kind of discouraged her, but I said, yes, you can come. So if we're talking about stress, that's for the first time ever, I have my parents in the audience right up there. That's right. And so one of the things I'd warned my mom about is I'm kind of talking about presenting some issues that might be kind of controversial. And so the first couple talks are about randomized controlled trials, and you might notice the question mark next to are they the gold standard? So, and she promised that she wouldn't jump to my defense if if I get given a hard time by people. But I found this CBT case conceptualization book. There's three questions. Can you help me is one of the first ones. And I really understand why RCTs are seen as the gold standard. And Lillian, I think, hit it right on. She used the word encouragement. I think it gives people encouragement. And in Sylvie and Brett's case, where there's nothing whatsoever, you can see why you do the RCTs before, really getting a firm grasp and understanding patients' symptoms. Whereas in other areas, like depression is where I've done my research, they've been doing trials for over 20 years. And not much, the progress has been limited, or the effectiveness has been limited. And but again, I think as long as grant funds, as the quote says, as long as grant funds continue to flow into the university or research institute, everyone's content. And but at the same time, at the end of the day, we know little about why these evidence-based techniques work at their limited effectiveness, and the contribution of research to understanding patient symptoms has been limited. So this leads us to a second popular question that patients have. Why does this keep happening to me? And most patients want to understand their difficulties, even with minor problems. So I've had this shoulder issue since I got back. I went to South Africa a month ago, and so I went to get it checked out. And so the therapist, he said, he tried to find the trigger points. What are the trigger points? So when I lift my arm, it's like, oh, And so, what triggers the problems? But also, so he was able to locate where the trigger was, but also what maintains the problem. And there's a knot in between my shoulder blades, so a knot. And then also, what strategies can help me learn to strengthen around the shoulder? And very much my interests are understanding better what triggers negative mood, what maintains negative mood, and what are the coping strategies and strengths that can help us become more resilient. And the thinking is a better understanding of the mechanisms of the disorder will inform the mechanism of the treatment or the theory of treatment, and this will facilitate the improvement of existing treatments. Okay, so much like CBT, our research uses daily diaries where we collect people's simultaneous reports of people's thoughts, moods, behaviors once a day for several days, and this is in their natural environment. And then we develop cross-sectional explanatory conceptualization. So we look for patterns. So when patterns in relation to trigger and maintenance of daily negative affect and low positive affect. So in terms of looking for triggers, what are the common cognitive behavioral triggers of increases in daily negative affect and positive affect across a wide range of situations for the typical individual? So we have several reports and for 14 days, and we have reports on days where their negative mood was higher than their average. So everyone has an average negative mood, but they also have days when it's high, when they have bad days, and days when it's low. And so everyone, they serve as their own control. And the advantage of this approach relative to a single case design, which is common in therapy, is you can do this on hundreds of people, and you can find out what are the common triggers for people across a range of stressful situations. And this, I think, has great potential for normalizing. So one of the big issues is stigma. How do we reduce stigma? And if we can show patterns that apply to several people across a range of stressors, that could be one way. And it's validating for the person. So daily stress generation trigger patterns. These involve interpersonal and intrapersonal appraisals, so perceived criticism, event stress, as well as coping strategies like avoidance that commonly work in tandem to trigger negative affect for the typical individual. So for a long time, stress was kind of seen as, according to this stress accidental perspective. So stress comes out of nowhere, and in its wake, you have depression. And then for a lot of patients, that's how it seems. The stress, they can't really identify the trigger. So kind of like the Wicked Witch of the East here, where the house just comes out of nowhere and falls on her and she's dead. Whereas in the 1990s, what became more increasingly popular was this stress generation perspective, and that's what individuals do to contribute to their own stress. And so in this instance, there's a squirrel missing a warning sign, which is fatal. And if you're continually doing that, then you'll tend to have more stress. Now, and another thing is the literature tends to have relied on simple explanatory conceptualization. So in here you see on days when people engage in avoidant coping, so escape, withdrawal, when they use that more than usual, they tend to have increases in negative affect. Likewise, when they perceive more criticism from others than usual, then they have increases in negative affect, as also when they have more stress. And this leads us to wanting to advance more complex explanatory conceptualizations. And this is a slogan from the film Surviving Progress, where the main theme was in 50,000 years we've made great strides in our technological progress. And that's because we've asked why questions, lots of why. And that's what really separates us from primates. However, psychosocially, we haven't really asked the why questions, really only in the last 100 years, starting with Freud. And that's why, our technology is kind of outstripping our psychosocial abilities, and the Earth's existence is threatened by things like global warming. So you have to ask why questions for understanding ourselves as understanding ourselves. So here's an example. On days when you engage in if you engage in more avoidance, escape, withdrawal, then your problems of that day tend to also be worse as well. And this is connected to feeling your increase in negative affect. And you can even go further, because avoidance is something that's hard to detect, because often patients are avoiding, they're concealing issues. So you want to, what are the signs? So one sign is if they perceive less control than usual, then that also is related to higher increases in avoidance and stress, and this is all connected to negative mood. Likewise, if they perceive more criticism, then they also tend to avoid have more stress, and this is also linked to the increases in negative mood. And you can also look at other outcomes, like positive affect. And so the slides that were in dark there, that's not a typo, but it's something you need to kind of, the image that's in shade, that's not a typo, but it's just a reminder you have to keep this other thing in mind, which is stress resilience. And it's an entirely different question and with different variables. And you have to bring these adaptive alternatives into focus. And therapists who look for strengths, they obtain a more holistic view of their clients. And I think both researchers and clinicians, they think people are there to have their problems solved. And in fact, this survey showed that not only do they want to have their problems solved, they also want to learn strengths. They want to learn how to function better. They want to feel normal. And so that's a relatively new thing that's been neglected for quite a while. And so there's what we call daily stress trigger patterns, which involves different variables. Interpersonal, like perceived social support; intrapersonal, perceived control, those kinds of appraisals, as well as coping strategies, positive reappraisal, and problem-focused coping that commonly work together to trigger daily affect for the typical individual. And so again, we have things that contribute or are associated with increases in positive affect on a daily basis, so perceiving more control over your stressor, engaging in active attempts to problem solve, positively reappraising the situation, trying to look at the positive. But again, you want to develop more complex formulations and try to connect the dots. And so on days you perceive you have more positive reappraisal of the event, then your stressor might seem more controllable. Maybe you'll adjust your goals, and this can lead you to more activation, problem-focused attempts, which is all connected to positive affect. Likewise, if you have positive support around you, this is also connected to perceiving like more adaptive strategies like positive reappraisal and problem-focused coping and positive affect. Now, a lot of that is arrows, and which is why it's particularly important. So therapists develop these cross-sectional explanatory conceptualizations, but you can't do it alone, and two heads are better than one. You need to test it out on the patient and see, does this jive with your experience? And the model can be used flexibly and according to what parts of the experience are most salient to the client. So there's really with something complex and rapid like this, there's no true single causal order, and it's what matters to the patient that's important. So in terms of interventions, you have a number of choice points to reduce distress. So lowering perceived criticism, increasing perceived control, reducing avoidance and event stress, and you also have choice points to increase resilience, like increasing perceived support, positive reinterpretation, perceived control, and problem-focused coping. So that's all about triggers, whereas on the other side of the coin is maintenance, and what kinds of personality factors and coping strategies keep mood down consistently. And I've focused on personality, and in particular perfectionism, and there's this notion that having relentless standards is in some way it's stressful, but at the same time you need that in order to drive yourself to better levels of performance. And this is reflected in cultural patterns, media, such as this quote from Andy Murray before the 2013 Australian Open. I hope it's a painful match because that means it will be a good match. And again, our cultural kind of preoccupation with outcomes and perfection, and putting people like Lance Armstrong as our role models to our kids and our youth coaches, and we point to the ones with clean records, gleaming smiles, and winning personalities. Yet when these people disappoint us, there's huge media coverage, which really reflects our preoccupation with this perfection. So what are the costs? So it's been associated with a wide range of pathology, like depression, suicide, eating disorders, anxiety. Also has a negative impact on therapeutic outcome and process. And so we want to know what are the mechanisms through which perfectionism maintains its distress over time. So now with any problem, there's strengths or adaptive capacities. It's not just negative. So there's parts of perfectionism that are adaptive or reflect a strength embodied within a problem. And so that would be personal standards, which is a tendency to set high standards and goals for the self. Whereas the more maladaptive parts are the self-criticism and constant harsh self-scrutiny and evaluation and worrying about others' criticism. And that's related to more persistent distress. So another question is, what are the typical appraisals and coping methods that self-critical individuals use that explains why they have persistently negative mood? And what are the adaptive coping strategies that personal standards individuals use? And it's the same samples of community adults and depressed patients. And they complete the measures in the lab session. And then they did these daily diaries of cognitive appraisals, coping, and affect. And then we use cross-sectional explanatory conceptualization. So we want to know, okay, someone has higher negative mood than others. So what was going on during those 2 weeks that explained why they had more negative mood? And that's to establish maintenance patterns. And so we found that self-critical people, they tend to avoid a lot of things across a number of stressors, and they tend to, and this contributes to why their problems are worse or is associated with it, and that can be an explanation for why they have more negative mood, as well as less positive affect. So to give you an example, this is George Costanza from Seinfeld, and he said, "Yeah, I'm a great quitter. It's one of the few things I do well. I come from a long line of quitters. My father was a quitter. My grandfather was a quitter. I was raised to give up." So now this is related also to higher levels of event stress over the 2 weeks. So they have more at stake with problems, focus on the negative, and this can also explain why they have more negative affect and less positive affect over the 2 weeks. But you just don't want to focus on stress generation. You also want to think about resilience. What resiliencies are they potentially lacking? And this can be in the form of less perceived social support, which is related to problem-focused coping, which means if maybe they did use perceived social support or had it, they would engage in more proactive attempts. Whereas on the other hand, personal standards individuals is indirectly related to positive affect over 2 weeks through problem-focused coping. Now we're just going to step back to triggers. And now as a personality researcher, I think one of my complaints is CBT, they focus on the here and now, what's immediate, and things like personality, that's you need a psychodynamic, or they tend not to even think about that, because that's, my wife has even said it kind of depresses her. So, but at the same time, if you really, because we know it's stable and intractable, but at the same time, if you really want to answer these questions, what are the triggers, maintenance, you need to consider personality. And so in the samples, they've done the daily diaries at month 6 and year 3. And you need to consider it because some people that come in are going to be more sensitive to others in stress. And that's exactly what we find over time at month 6 and year 3. On days when they experience an increase in stress, they have greater levels of sadness relative to people who aren't self-critical. Likewise, they have, on days they perceive less control, they have greater increases in sadness relative to low. And then they're also more sensitive to negative social interactions, so they have heightened concerns of rejection and criticism, and that's why that kind of pattern would persist over time, and it's something I think clinicians should be attuned to. Okay, and the same for avoidance. That's another stable coping, so if they avoid, they're not going to achieve their goals, and that's also related to greater increases. So I think along these lines of perfectionism or even mental illness being, 5 minutes. Okay, I thought I was pressed for time. Sorry. Okay, so I can take a breath then. Okay, so here's see a lot of these slides. My daughters, they watch these. We've been showing them Back to the Future and Wizard of Oz and that. So that's where a lot of these are. But I think science, a lot of mental illness and even personality, it kind of portrays a a depressing image. So this is the scientist. I don't know if you've all seen Back to the Future. It's a classic. But in the beginning, he says, if my calculations are correct, when this baby hits 88 miles per hour, you're going to see some serious, and I won't say the last, but you're going to see some serious stuff. So, and that's kind of, I think, we show that, depression's recurrent, it's chronic, mental illness it's a very grim portrait. And whereas I think focusing on mechanisms, you can maybe give a more positive view. So this is at the end of this trilogy where Doc Brown says, your future hasn't been written yet, no one's has, your future is whatever you make it, so make it a good one. And and again, and this is this is the third question I had, was does my future look like my past, which is, it would be another really relevant question and one that Sylvie, am I going to relapse, sort of thing. But so basically we want this to empirically inform a prevention or clinical intervention strategy. And you should should assess for personal standards and self-critical aspects of perfectionism. And so part of the strategy would be to focus on antecedent focused emotion regulation. So the suggestions are to decrease the maintenance of depressive and anxious symptoms and self-critics. You want to lower daily stress and avoidant coping. And to increase positive affect, you want to increase perceived social support, positive reinterpretation, and problem-focused coping. And then with those stress reactivity findings, I think that's true. And I've had patients say, this reacting when I don't have control and I get all wound up and stressed out, that's just who I am. And I think in the past I would try to change that. However, and there's a third wave of CBT where you help people adjust to that reactivity. You don't necessarily try to change it, but you try to change how they respond to it. So they're gonna be reactive. So yes, their future does look like their past. They're going to continue to be reactive. But what you do try to change is how they cope with that and their self-destructive patterns or behavioral avoidance in response to that reactivity. So in conclusion, daily diary methodologies and MSEM multi-level modeling can be used to advance complex explanatory conceptualizations and promote a shared understanding between therapists and clients of common stress generation and stress resilience triggers that are connected to mood shifts for the typical individuals, stress generation and stress resilience maintenance factors that keep mood down for personality vulnerable individuals, as well as heightened stress reactivity and coping ineffectiveness, which occurs for some personality vulnerability individuals over time. So those are my acknowledgments of my mentors, collaborators, students, postdocs, and funding agencies.